Hello and welcome to Keep Talking, a community dialogue about mental health. My name is Gay Maxwell. I'm the manager of the continuing education program at the Brattleboro Retreat. The Brattleboro Retreat is a 180-year-old psychiatric and substance abuse treatment hospital nestled in southeastern Vermont. We serve adults, adolescents, children in outpatient, inpatient, residential, and partial hospitalization programs. And today we are very blessed to have our director, our clinical director of our uniformed service program, coming today to talk about our uniformed service program. This is Susan Balaban. She is a clinical psychologist and has a lot to say about uniformed service professionals and what brings them to the retreat. So first, let's start off with what is the uniformed service program?
So the Uniformed Services Program is a mental health and substance abuse treatment program. It's a partial hospitalization and intensive outpatient program. So it runs 7 days a week, and it's designed specifically to meet the behavioral health needs of people who are coming from backgrounds in law enforcement, military, firefighters, and some other disparate areas. We've had drug enforcement agency, that's law enforcement, but some pretty far-flung areas. Emergency medical services, so paramedics, and occasionally some people who work in emergency rooms at hospitals. So.
What were the ideas about putting this program together? This program started what year?
5 years ago. So it was I believe the what's the expression, brainchild of Rob Simpson, the CEO from the retreat, to have a program that served military personnel and other people who served in uniform, out of being able to give back, being able to honor those groups of people that do so much for other people and can often develop a lot of behavioral health problems in the work that they do. So I think that he was inspired by being able to do that. And when the program started, I believe that the primary focus was on trauma, and that is still very much informs what we do. But I think that we've expanded our expertise in other areas, so into substance abuse treatment. The chief of substance abuse is now our regular physician, Dr. Kane. We specialize in sleep difficulties, in chronic pain, and certainly in depression and other types of anxiety besides PTSD. So we've really brought in to be able to meet the broad healthcare needs, or broad mental health care needs.
I think a lot of people imagine the stereotype fireman, policeman, person in uniform as being very strong and hardy and able to take care of themselves and the people around them really well. And so they might be surprised that they present or they are suffering from something like post-traumatic stress syndrome. Maybe you should talk a little bit about post-traumatic stress syndrome and what that actually looks like.
Well, it's interesting because I think that I come from a certain bias, which is working with hundreds of people coming from uniformed services. So I can speak a little bit better to what it looks like in them, which is that it's because this is a population that prizes stoicism. It can be hard to read. It can be hard to see the signs. So, and that very sort of discomfort with being emotionally expressive, or with, admitting to themselves or to others that there is a problem, can cause problems, or can actually exacerbate PTSD, make it more severe, more chronic.
Let's roll back, though, to the symptoms of
PTSD,
PTSD, or post-traumatic stress disorder.
So most people, at least in this population, or I would say for most populations, like if most groups of people, if they have very overwhelming events happen to them, they'll have some form of acute stress response to that. Increased anxiety, difficulty sleeping, being very upset by reminders of the event, but usually that remits over weeks, usually goes away pretty quickly. What happens with very pronounced post-traumatic stress disorder, where is that a person will have those symptoms come up, but we call them re-experiencing symptoms. So things like nightmares, flashbacks, having thoughts and memories and physical like tension, anxiety, hyperarousal come up, and they'll do whatever they can to suppress that. So that can look like, even in a person's, you might not see them doing it, but they might just say, think about something else. I can't have that. Mm-hmm. I can't be that. I'm supposed to be strong.
I can't be that.
I can't be traumatized. I can't have that memory. And that memory is going to overwhelm me, and it's going to make it difficult for me to live the way that I'm accustomed to living. So
it's like the memory gets in there and is kind of like a toxic.
They try to tamp it down.
Mm-hmm.
Try to, almost like a beach ball, try to push it under the water,
mm-hmm.
and it's as soon as you let go, it pops up. So
mm-hmm.
they call those intrusive thoughts, because that's usually how people experience it. And
intrusive thoughts.
Yeah.
Mm-hmm.
So most people who have had traumatic experiences will have some degree of these re-experiencing symptoms, but it's the avoidance of having them. So it can be just things like, trying to for people to try to put it out of their minds, or to try to distract themselves, or to avoid talking about it. But it can also be drinking alcohol to numb themselves. We see a lot of that because it's sort of historically, it's a culturally, acceptable or endorsed way of handling stress, particularly in these fields that have a lot of stress attached to them. Mm-hmm. Also, even healthcare providers who are very well-meaning, they might prescribe sedatives, and sedatives that artificially suppress the stress response. Essentially, it makes it so that a person can't re-knit the parts of the brain that are affected by overwhelming stress, that they don't come back to the same threshold for stress. So all of these different ways of avoiding stress actually serve to lower a person's threshold to stress, so that they're more vigilant, so that they're physically in a more stressed state a lot of the time.
But why would there be a special program? Why would, for instance, you hear about all kinds of things mm-hmm. that victims of war and rape victims, murder, there are all kinds of situations that people get themselves into that might produce post-traumatic stress syndrome. Why a separate program?
That's a great question. For as wide a range of careers as people come from, it's amazing how well they knit together and are supportive to each other. So in addition to doing some really hard work around trauma, for the people that are there for trauma, because mm-hmm. people come for other reasons, in addition to doing really hard individual therapy and hard work in the groups, they also come back during groups that focus on peer support, or outside of, when they leave treatment, they're still a source of support to each other. And their shared experiences are very validating to each other. So if, firefighters, for instance, are so good to each other, at work, but there's a tremendous stigma around having PTSD. Firefighters who are in the Uniformed Services Program can speak very openly about their experiences.
So it sounds like you're building a place of safety where
Exactly.
people will be surrounded by people in similar circumstances
Exactly.
who understand where they're coming from, but they can also do the work they need to do
Exactly.
to heal.
Exactly.
Yeah.
I think that there's something about that shared experience and about knowing that this happens to other people that look strong, that have, strong values, that that have done really good work and have functioned very highly. I think that seeing that other people struggle with this as well, and that there doesn't have to be something wrong with you in order to develop PTSD. So,
So what are some of the myths about PTSD that if you were to, if you wanted everybody to know, you would talk about? And you have the opportunity right now.
Absolutely, and I have strong feelings about this. I'm going to focus on the ones that are uniform service specific. I think that there is, to some extent, in military culture, there is this idea that PTSD is not curable. And I think thinking of something as either being incurable or curable isn't really a useful way of thinking about PTSD. Like addiction or like chronic pain, healing from PTSD is a recovery experience where you begin to, you incrementally are able to re-engage life and become less anxious in the presence of things that either could potentially cause you anxiety or are actual reminders of the traumatic experience or experiences. So that's the first piece, that a person can't move into post-traumatic growth and can't go back to the work that they were doing before. So I've seen people heal through going back to work. Firefighters who were worried that they'd freeze, going back into.
You had said that that's somewhat part of the treatment is to prepare them for those exercises.
Yeah, and if that's something that they want to do. So the way that we approach treatment is very much about being able to allow people to process trauma, but also to have them focus on doing in life the things that they find meaningful. So for one person that might mean going back to work, for another person that might mean doing an entirely different type of work, or being able to spend more time with their families. It's about, for each person, sort of what in their gut they want to be able to do if they're able to move beyond being stuck and being paralyzed by having to seem a certain way, or by fear.
And
so.
I wonder also about, I think there's sort of ideas about what is and what isn't PTSD. Well, he has nightmares, he must have PTSD.
Right.
He's jumpy, he must have PTSD. It can look different in different people, correct?
Yes, and that's a really great point. So for very good reasons, there are some distinct sets of symptoms. So what you're describing and what often gets talked about the most are these re-experiencing symptoms. But a person can never be diagnosed with PTSD if they don't also exhibit these avoidance behaviors. And part of that is that they give a very good explanation for why a person develops chronic severe PTSD. And then beyond that, for most people, particularly maybe this is true for other fields as well, but for this field, there are a lot of types of experiences that lead to ways of thinking that perpetuate PTSD. So, for instance, I've heard so many people coming from law enforcement or firefighters who talk about things going the way, textbook. It went the way that it was supposed to go, and no matter how severe what happens seems to me, like people were killed. It was a huge fire. For people who are in the military, the mission, people were killed. But things went the way they were supposed to go. The people that were there to back you up got there. You arrived in the right place. You didn't lose someone. So those types of experiences don't really shape thinking around self-blame and blame of others. And that seems to be very prominent in so there's another cluster of symptoms that's around how people with PTSD think. So having sort of a negative view of the world and the future, and self-blame and blame of others, and sort of a preoccupation with that.
You talk about negative feelings about the world. Does PTSD often go hand in hand with depression?
That's a very interesting question, because even more so with recent revisions to the diagnosis, but going back, I'd say at least a decade, there has been I'm not even sure how far this goes back, but symptoms of depression have been part of the PTSD diagnosis. And sometimes I think that, depressed mood, or actually I think they call it negative mood, but negative mood and anhedonia, sort of a lack of interest in things that used to be interesting.
So if
sleep
you loved,
difficulties.
If you loved fishing and all of a sudden
Yes,
you can't get
it's
yourself
no
off the
longer-
couch
Exactly.
to go fishing, or
Exactly.
if,
Exactly. And a sort of negative and stable worldview. And all of those are included in the PTSD diagnosis, and I think that it's possible that they get diagnosed together, just to sort of make sure that, for people doing the diagnosing, that we're expressing that this person is struggling not just with the sort of hyperarousal and hypervigilance, sort of being in a very amped up state, or very agitated state, but also that depression is very much a part of the picture. So that might be why they're often diagnosed together, even if the symptoms of PTSD capture most of the depressive symptoms. I don't know that I've ever met anyone who had PTSD that didn't struggle with depression. So,
so that's something that a family member might see, as opposed to see the stuff.
Very good point.
That is being buried.
Definitely, anger and depression could be the most prominent things. Even if there isn't substance abuse, we see a lot of other addictive behaviors, compulsive spending, gambling, anything, some extramarital affairs. We see a lot of stuff that it's just about being able to quickly experience relief from feeling dread and anxiety, and also perhaps the sense that family members might view them as being broken. If they can be in a situation where they're not viewed that way, where they're just having fun, then that crops up as well.
In your work, what do you feel is the thing that usually brings people to pick up the phone and look for some help?
Usually, to get to this level of care where they're not going to be doing this on a weekly basis, it's usually because their behavior has gotten to such a point that it's causing problems in other areas of life, and they're distressed about it. So if it's causing, if they're angry a lot of the time or withdrawn a lot of the time, that's affecting their families. So either their family members are telling them to get treatment, or they're upset with themselves about not being able to function better and fit in their families. Also at work, if they're noticing that they're having conflict with coworkers, or that
Irritability.
Yeah. In law enforcement, having engaging with the public in a way that feels like this is I'm a little out of control here, or I'm angrier, or if they're being told by the people that they work with that that's the case. If they're having trouble keeping up with work, or getting into trouble at work in other ways. So often they'll hear from the people around them, what's hard to admit to themselves.
Do people come from everywhere to come to this program, or is it mostly Vermont folks that come?
That's a great question. Most of the people that come to the program come from the Northeast. I wouldn't say mostly Vermont, and I think that just because of the population, the places that are more dense, like Boston and New York City, and so we get a lot of people from New York State, upstate and downstate, a lot of people from Connecticut, a lot of people from Massachusetts, and some from New Hampshire and Vermont.
Well, that sort of leads into my next question about what does it look like when somebody arrives? Who brings them usually?
Yeah.
What does it look like?
So this doesn't feel like being in the city. This doesn't feel like being, with the counseling unit, with our department. And I'd say that they are quickly able to make some peace with that, I think, for a couple of reasons. One is that I think it's fun for them to sort of be in a different atmosphere, where most of the people that work in our program, not myself actually, but a lot of the people that work in our program have backgrounds in the uniformed services, so that becomes more clear the more time they spend there. Our treatment program is behaviorally based, so it's very much focused on what people can do in order to move themselves to greater well-being or on a path of recovery. And I think that it appeals to people who want to be able to take charge.
So they're not. So it's not a situation where people would imagine themselves lying on the couch and talking to the analyst.
No,
right. It's not like that at all.
Definitely not. And for a lot of people, this is their first experience in therapy. So. They may have seen things on TV, and it's particularly group therapy can be a little bit challenging when they first get there, because again they're sort of expecting that their peers will judge them for having problems, and for experiencing anxiety, and then they hear people sharing their own experiences, and then that starts to go down.
So it sounds like there's individual therapy, there's group therapy, and should these people, anybody who wanted to come to this program, would they, should they imagine themselves getting tucked into hospital beds at night? Because I did say when I introduced this program that the Brattleboro Retreat is a hospital.
No,
that could be a misconception.
That makes a lot of sense. So we are a hospital-based outpatient unit. And we do partial hospitalization, the full day, 7 days a week, and intensive outpatient programming, which is either half days, 7 days a week, or we can tailor to if someone wants to be able to go back to work, or wants to be doing more independent, has more independent exercises to promote their health, then that can be done on an IOP basis, on an intensive outpatient basis. So when they leave program for the day, there are a couple of different lodging arrangements that are managed by the retreat, but anybody who's coming locally commutes. So
you can live at home and go to this program if you need to.
Exactly. So. Most of the people that are coming to us from Vermont, northern Massachusetts, New Hampshire, or southern New Hampshire, southern Vermont, are commuting.
So that is a different way of looking at this program. Is there help for families? Because I can imagine if you are a person who is living with somebody who has this irritability, anger, probably withdrawal, maybe testing your marriage, your relationship in some ways, that they've kind of gone through their own dark night of the soul.
Definitely. And that's actually what, so we do counseling while a person is within our program, usually with their spouses, but if they have adult children, or if they want help in being able to explain to younger children what's going on, then we help with that. What we focus on while a person's in treatment is usually being able to speak with partners and have them be able to say how this has been for them, so that and also to bring up their concerns, so that they feel like they they have sort of buy-in and support for what a person's doing in the treatment, and we are sort of honoring their experience. A lot of psychoeducation around what PTSD is, how chronic pain and depression and problems around substance abuse might make PTSD worse. So a lot of psychoeducation, and then when a person leaves, we ideally can do a second meeting, either in person or sometimes we have to do it over the phone if somebody's in Montana. So,
speaking of going home, what do you hope that people will take home with them?
That's a great question. It's actually very embedded in our treatment model, this idea that people recover through not just feeling less stressed or not doing certain things anymore, but that there are things that they need to do in order to continue to recover and heal. So when it comes to PTSD, we usually are mapping out with people things that they really want to be able to do. That.
What might that be? Give me some examples.
So something like if they've had particularly conflictual relationships with their adolescent children, being able to sit in that conversation and listen, and to go about the conversation in a different way. So they would practice that with us, and then they would actually rehearse it, and then go out and do it.
Let me ask you just one more thing, and that is, what would your overall message be to people out there who might be watching this, who might have a loved one who they think might be suffering in this way and could and need help? What would be your message to them about recovery and healing?
That it most certainly is possible. That most of the therapies that work for PTSD tend to be brief therapies, spanning between, if it's done in a program like this, it happens over several weeks.
Short term.
Yeah. Or, if it's done on an outpatient basis, it would be done, 8 weeks to 12 weeks. But that's not, PTSD isn't cured in that amount of time. And being able to re-engage
it's
in
not
life.
Cured.
No.
No.
But being able to re-engage in life in a way where a person is doing the things that they want to be able to do in the presence of anxiety allows for that anxiety to continue to come down. And, I saw someone who was with us 2 years ago. He was, more calm than, and I'm pretty tightly wound, but he was more calm than I am now, practicing mindfulness every day and still working as a firefighter going into fires. And again, it's PTSD does not mean that you're broken.
That's a great way to end the program. PTSD does not mean that you're broken.
No.
So Susan, thank you so much for giving your time today to do this interview. It was really fun. It was really interesting for me to listen to. This is Susan Balaban. She is the clinical manager of the Uniform Service Program at the Brattleboro Retreat. She's been here and had a great conversation with her. I want to thank you for joining us for another episode of Keep Talking, a community dialogue about mental health. And I look forward to interviewing other people and having you as an audience. Thanks.